Hi students, good afternoon everyone. Today we'll discuss about the diseases of maxillary sinus. The diseases of sinus are mainly classified into intrinsic and extrinsic diseases based on the origin. Intrinsic diseases are those which arises within the maxillary sinuses. The intrinsic disease again classified into inflammatory diseases and neoplasms. Inflammatory diseases includes mucositis, sinusitis, empyema, retention pseudocysts, polyps, androlytes, and mucosis. Benign neoplasms includes epithelial papilloma, osteoma. Malignant includes squamous cell carcinoma and pseudotumor. Extrinsic diseases are those diseases which occurs outside the maxillary sinus. They are inflammatory diseases, which includes periostitis, benign odontogenic tumor census, and fibrous dysplasia. Traumatic injuries to the paranasal sinuses, dental structure displaced into the sinus, for example, root stumps. The general clinical features are feeling of pressure, altered voice characteristics, pain and movement of head, percussion sensitivity of the teeth and cheek region, regional paresthesia anesthesia, swelling of facial structures adjacent to the maxilla. The diagnostic aids includes intraoral periapical radiograph, lateral maxillary occlusal radiograph, orthopantomogram, skull views, computed tomography, and MRI. The intrinsic diseases, the main intrinsic disease of the sinus is inflammatory diseases, which are caused by infections, chemical irritation, allergies, and introduction of foreign bodies or facial trauma. The first inflammatory disease is mucositis. The normal mucosal thickness is 1 millimeter. If it is more than 3 mm, we consider as a pathology. And in case of mucositis, it may increase till 15 millimeter. Radiographically, it appears as non-corticated band, which is more radiopaque than air-filled sinus, paralleling the boli wall of the sinus. So as we see in this diagram, this is the floor of the sinus, and this is the thickness of the maxillary sinus, which is increased in case of mucositis. The second inflammatory condition is sinusitis. It's nothing but generalized inflammation of paranasal sinus mucosa. Main etiological agents are allergen, viral, bacterial, or viral infections. They are classified into 3 types based on duration. Acute sinusitis less than 2 weeks, subacute sinusitis 2 weeks to 3 months, chronic sinusitis which is more than 3 months duration. Pansinusitis is nothing but inflammation of all the paranasal sinuses. The clinical features of sinusitis occurs due to common cold accompanied by clear nasal discharge or pharyngeal discharge. Patient often complains of pain and discharge and tenderness and percussion over the involved sinus. This pain may refer to the molar and premolar teeth on the affected side, and the teeth appears tender on percussion. There will be green or yellowish discharge from the nasal cavity. Patients also complains of fever, chills, malaise, and an elevated leukocyte count. Chronic sinusitis occurs due to anatomic derangement that inhibits mucus outflow, includes deviation of nasal septum and presence of concha bullosa. The radiographic feature of sinusitis is nothing but localized mucosal thickening along the sinus floor. The generalized thickening of mucosal lining along the entire wall of the sinus and near complete radiopacation of the sinus. As we all know that sinus usually appears radiolucent due to airfill, but in case of sinusitis due to accumulation of mucus, so it will become radiopaque. The image of thickened sinus mucosa on the radiograph may be uniform or polypoid. In allergic condition, the mucosa will be lobulated, and infection, it appears uniform with smooth border. The treatment for sinusitis is to control infection, promote drainage, and relieve pain. Acute sinusitis will prescribe nasal decongestant to reduce mucosal swelling. In bacterial sinusitis will give antibiotics. And in chronic sinusitis drainage by endoscopic surgery. The third condition in inflammatory disease is retention pseudocyst. Etiology is blockage of secretory ducts of seromucous glands in the sinus mucosa that may result in pathologic submucosal accumulation of secretions resulting in swelling of the tissue. The serous non-secretory retention cysts arise as a result of cystic degeneration within an inflamed thickened sinus line. Both the lesions are called pseudocysts. The clinical features is they can occur any time in the year and mainly involve any sinus around the month of April to November. It may show seasonal variations. Males have predilection, asymptomatic, but when the cyst enlarge, it extrudes through the sinus, causing nasal obstruction and forced nasal discharge. Maxillary sinus is the most common involved structure. The radiographic features includes the pseudocysts may be unilateral or bilateral, and they appear as non-corticated, smooth, dome-shaped radiopaque masses. The radiopacity is homogeneous and it's more radiopaque than air-filled sinus. No effects on surrounding structure. So as we see in the right maxillary sinus, there is a dome-shaped radiopacity. We can well appreciate it on the orthopantomogram. The differential diagnosis for retention pseudocysts are odontogenic cysts like radicular cyst, odontogenic keratocyst, and antral polyps. This is usually a corticated border and there will be loss of lamina dura. The floor of the sinus may be missing or displaced. No treatment is required for pseudocysts. The next inflammatory condition is polyps. The thickened mucous membrane of chronically inflamed sinus frequently form the irregular folds. They are called polyps. The polyps usually cause displacement or destruction of the bone. In ethmoid ulcers, polyps may cause destruction of medial wall of the orbit also. The radiographic features of polyp is they usually occurs with thickened mucous membrane lining because the polypoid mass is nothing but an accentuation of mucosal thickening. It may cause displacement and destruction of the bone. So next condition is androliths. Androliths occur in sinus due to deposition of mineral salts like calcium phosphate, calcium carbonate, and magnesium around a nidus, which may introduce into the sinus and the condition may be intrinsic. These androliths, they are usually asymptomatic when they are small, but as they grow, patient may complain of sinusitis, blood-stained nasal discharge, nasal obstruction, or facial pain. Coming to the radiographic features of androliths, they usually occur in maxillary sinus and always positioned above the floor of the sinus in case of periapical radiograph. And they are well defined and are smooth and irregular in shape, appears radiopaque. The differential diagnosis for androliths is root fragments or rhinoliths. The rhinoliths usually occurs in the nasal cavity. So as we see in this orthopantomogram or OPG, we'll see a well-defined radiopaque mass on the distal wall of the sinus. Coming to the next inflammatory condition, that is mucocele. It's an expanding destructive lesion that results from blocked sinus ostium. The blockage may be due to intra-antral or intranasal inflammation or polyp or neoplasm. The mucocele in the sinus exerts pressure on the superior alveolar nerves and cause radiating pain. Patient often complains fullness in the cheek and the area may appear swollen. As it expands inferiorly, it causes loosening of the posterior teeth. If the medial wall of the sinus is expanded, the lateral wall of the nasal cavity will deform and the nasal airway may be obstructed. Radiographic features, this condition rarely seen in maxillary sinus. The normal shape of the sinus changes into more circular shape as the mucocele enlarges. The internal structure usually radiopaque. So as we see in this OPG on the left side, we can't differentiate the floor of the sinus because of its radiopaque mass. The effects on surrounding structures. The septa and bony walls may be thinned or destroyed. When occurs in maxillary sinus, the teeth may be displaced or roots resorption may be seen. The differential diagnosis for mucoceles are cyst or neoplasm, but this mucocele always associated with the occluded ostium. Management is surgery through Caldwell loop operation. The second intrinsic condition is neoplasm. The benign neoplasms like epithelial papilloma and osteoma occurs in paranasal sinuses. Osteomes more frequently occurs in male when compared to female in the ratio of 2:1. Most predilection in second, third, and fourth decade of age. They are slow growing and usually asymptomatic. Radiographic features. So in case of maxillary sinus, it appears as lobulated or rounded and have sharply defined margin, which appears as radiopaque. The differential diagnosis for benign neoplasms is androlith, mycolith, odontogenic neoplasms, and odontomas. The malignant neoplasms, squamous cell carcinoma originate from metaplastic epithelium of the sinus mucosal lining. Clinical features, cancer in sinus causes facial pain or swelling. nasal obstruction, and a lesion in the oral cavity. Most frequently occurs in older age group, and males are most frequently affected. The symptoms depends on which side of the sinus wall is affected. If the medial wall is eroded, we'll see the obstruction, discharge, bleeding, and the pain. In case the lesion affecting the floor of the mouth, it produces dental signs, symptoms like expansion of the alveolar process, unexplained pain without any carious lesions or periodontal pathology, numbness of the teeth, mobility of the teeth, and swelling of the palate or the alveolar ridge. These neoplasms can erode the palate and may penetrate into the oral cavity also. Most commonly affects in maxillary sinus. It destroys the sinus walls and causes irregular radiolucent areas in the surrounding bone. Also causes irregular widening of the periodontal ligament space, and the medial wall is thinned or destroyed. So as we see in this OPG, it's an edentulous patient. When compared to the right side, the left side of the sinus is completely destroyed by the neoplasm. The differential diagnosis are sinusitis, large retention pseudocyst, and odontogenic cyst. Treatment is, so as for all other malignancies, surgery and followed by radiation therapy. Coming to the extrinsic disease of the paranasal sinuses, the first inflammatory condition is periostitis. The exudate from dental inflammatory lesions can diffuse through the cortical boundary of the antral floor. So these products can strip and elevate the periosteal lining of the cortical bone of the floor of the maxillary sinus, stimulating the periosteum to produce a thin layer of new bone adjacent to the root apex of the involved teeth. So when you see in this intraoral periapical radiograph, we can see a radiopaque line surrounding the periapical region of the maxillary second molar. So this new bone formation always take one or more thin radiopaque lines, or it may appear maybe very thick also. This new bone is directly centered over the inflammatory lesion. The second condition is benign odontogenic cysts and tumor. So the odontogenic cysts are the most common extrinsic diseases of the maxillary sinus that involve the sinuses. The most common cysts involved are radicular cysts, followed by dentigerous cysts and odontogenic keratosis. As the odontogenic cyst grows, its border becomes indistinguishable from the sinus border. With continued growth, the cyst encroaches on the space of the sinus, displaces its boundaries, and air-filled space decreases in volume. A thin radiopaque line divides the content of the cyst from the sinus cavity. Coming to the radiographic features, the periphery and the shape, the invaginating cyst has a curved or oval shape defined by a cortical border. The internal structure of the cyst is homogeneous and radio-opaque when compared to the air-filled sinus cavity, which appears radiolucent. The degree of radio-opacity may appear to be that of bone, resulting from the extreme contrast to the radiolucent air within the sinus. Coming to the effects on surrounding structure, the cyst may displace the floor of the maxillary sinus. The large dentigerous and odontogenic keratosis can displace the third molars as far as to the floor of the orbit also. In some cases, the cyst may enlarge to the point that it has encroached on almost the entire sinus, and the residual sinus space may appear as a thin crescent of air adjacent to the cyst. So this is the diagram showing how the initial cyst progresses to the large size, so it occupies the entire maxillary sinus. So these are the few intraoral periapical radiographs showing a well-defined cortical boundary of a odontogenic cyst, and this is a radicular cyst. Second condition is fibrous dysplasia, which may arise adjacent to the any paranasal sinus, causing displacement of the sinus borders and results in smaller sinus on the affected side. Coming to the clinical features, the involvement of the facial skeleton with fibrous dysplasia can result in facial asymmetry, nasal obstructions, proptosis, that is increase in the intercanthal distance, pituitary gland compression, impingement of cranial nerve, or sinus obliteration. Sinus obliteration results when expanding dysplastic bone encroaches on it. The lesion may displace the roots of the teeth and cause the teeth to separate or migrate, but usually does not cause root resorption as compared to the cysts or tumors. Fibrous dysplasia more common in children and young adults, and growth of the dysplastic bone usually ceases at the age of the skeletal maturity. Coming to the radiographic features, so most common site is posterior maxilla. The lesion itself usually not well defined, tending to blend into the surrounding bone. The external cortex of the bone as well as the floor of the sinus is intact but displaced. The internal structures, the normal radiolucent maxillary antrum may be partially or totally replaced by increased radiopacity of the bony lesion. The radio-opaque appearance in the fibrous dysplasia has characteristic ground glass appearance on external